Hello, doctors and team members. I appreciate you dedicating this next hour in understanding what I've been struggling with probably for the past 14 years of not just necessarily placing attachments or engagers on teeth while doing clear aligner therapy, but how to remove them, really removing them safely and not damaging the enamel. I'm Dr. Atai, and those of you who have heard or know of me or have seen me on the lecture circuit, I've been in the clear aligner lecture circuit for over 14 years and now treating over 2,000 patients. I think now I'm close to 3,000 these days of clear aligners. I've provided treatments of multiple clear aligner companies from Invisalign was where my starting, and including ClearCorrect and SureSmile and a couple of other companies, and most recently with the Spark and Ormco products that's being launched. So I've done a lot of beta testing for clear aligners, done a lot of attachments and product testing for composites and resins and what works best. And most importantly, having this conversation with you at home. I understand we're all having to be safe, and some of you are probably just at work with the webinar. I appreciate your time. And, as you can see, we've all been wearing our mask at the family with my wife and two kids. So let's get right to it. The main objective tonight is to make sure that we understand the benefits of just the material that we're using in composite for the attachments. And what I like to talk about is the bioactive Guymer technology. I'll be introducing to you about conversations of what is Guymer and why is that important in our resin material, specifically for attachments as well, and how to remove them, really how to remove them without damaging the enamel and effortlessly putting them on. Because I know in some states, there's rules and regulations against assistants or extended function assistants putting on attachments, and some states there aren't. So generally speaking, when a doctor has 0 patients and chair time and etching and bonding, you put on the attachment, you cure it, you hope it works, and then a day or two later, the patient comes back with the attachment popped off. Sure enough, you go back and re-etch and redo everything, and it still sometimes pops off. So I want to talk about that and not getting bubbles in those engagers or attachments that when we're in the middle of clear aligner therapy or at the beginning of it. And really understanding composites, composite resins, and the bioactive material called Guymer is something that I was educated in about 4 or 5 years ago, and I've been having gone back. So I want to talk a little bit more about that in making sure that as we're kind of going through, you understand that there is multiple options within our dental office. So let's get right to it. Importantly to understand is the clear aligner capacity. So those of you who are, using, let's say, Invisalign or ClearCorrect or any other product, these are standardized torque movements on the plastic. So I understand that one company may have a different plastic, and their claim to fame, maybe it's superior, it's better. But at the end of the day, the treatment design and the planning and the software is unique to each of these companies. And, those of you who see now a company like a SmileDirect that's now coming on board in trying to get GPs and general practitioners into their fold where they were do-it-yourself model, you realize, well, how was it that these patients are doing the at-home treatment without any attachments or engagers? And then here we are in the office, and we've got almost molar to molar that the software tells us to put on an attachment or an engager. And the reality is that we have to understand that there's a parameter of treatment that an aligner can actually have a certain torque built in. So for instance, most companies have aligner torques of anywhere between 0.25 to 0.35 as per aligner torque movement. Well, if that is the case, then what we've got ourselves is that it doesn't matter what plastic, or does it? It doesn't matter what engager goes on what tooth, or does it? And the answer is, depending on the surface size of the tooth and the actual surface area given from a gum gingival on up, because that's what the aligners are really grabbing, that structure is dictated of whether or not an engager or an attachment is needed to rotate, to extrude, to intrude potentially. So when you start to look at the different aligners out in the market and you start to kind of really break it down, and you realize that if there is a 0.25 or 0.3 torque movement per aligner, how and which teeth are moving. And those are the teeth that at that point, if you're doing a rotation, for instance, you would need to put on that composite resin on the tooth to engage or attach itself with the aligner to give it more, if you will, grip. And that is the confusing part where a lot of doctors want to have a conversation. They're like, well, these patients are doing it at home and it looks like they're doing it successfully. How is it that we have so many attachments on our plate and on our software? So again, it goes back to the teeth size, shape, and the actual movement you're trying to do. So for instance, in a spacing case, in this particular case, in her initial, as you can see, she had spacing. Spacings are less than 2 or 3 millimeters. It looks less than 4 millimeters of spacing total. Spacing cases are ideal. But if you look, she's got a little bit of a short clinical crown and she's got some abfractions. She's got some areas on the bicuspids that are receded or abfracted potentially from clenching, grinding, or malocclusion. And you can see that the tops of her teeth are completely flat. A patient like this, the question would be, do they need attachments or engagers? Do they need something to grip the aligner better? My answer to you is, if it's a spacing case and you're simply pulling teeth back and you're putting teeth into an ideal position, meaning you're lingualizing, you're closing spaces, there's really no real IPR, there's really no rotations that you can see. Her lower and upper arch are U-shaped. They're within the parameter of clear aligner therapy that we can now kind of tip everything back and tighten the arch, if you will, to remove the spaces without any engagers, without any attachments. So in this particular case, less than 4 millimeter spacing, less than a year timeline, obviously, patient was able to just change the aligners. And by changing the aligners and that 0.25 torque movements were enough to kind of pull her teeth back and put her in a position where the spacings are closed. Now, when you look the aligner that is on her teeth, some companies claim that their goal is to have the aligner that's above the gingival, and it's grabbing the gingiva and teeth and grabbing everything and pulling back. Other companies say, no, we actually do a stippling around the gum line and we only touch the teeth. And again, it goes back to that torque movement and what you're trying to perform. In terms of spacing, less than 4 millimeter spacing, very simple, clear aligners. It doesn't, I mean, I can close my eyes and watch these teeth come back and put it in class 1 occlusion. When you start to get into a more of a severe class of crowding, if you can see here in our patient that you can see I've been treating with other clear aligner systems, there's a bicuspid that are on the lowers that are kind of omega shaped and they're tipped in. And to look at this case, this particular case is going to definitely need some sort of an intervention of potentially either lingualizing, but given the patient was a class 3, pseudo class 3, my goal was I can do the lower bicuspid extractions because they're tilted beyond 20 degrees and they're almost on the floor of the mouth. As you can see from a buccal view, you can barely see any bicuspids. And we decided that ideally the lowers bicuspids can be extracted. And if we extract those lower bicuspids, then at that point, I can deliver the aligners. I would now need some sort of attachment engager to pull that lower arch and tip it back behind the upper arch in giving this particular patient, and this photo, as you can see, right after extraction, in giving that patient the ideal class 1. So now we have to close these bicuspid spacing as well as the lower crowding that you can see. And this would need an engager or an attachment, definitely an attachment. And I would kind of try to put a better U-shape to the upper arch. As you can see, it's kind of narrowing, and it looks to be a little bit narrowed arch. And you can see that I put engagers on the anterior teeth, or attachments rather, and those attachments were extrusion attachments. My goal was to extrude canine to canine down so I can lock it into position. As the lower arch now is getting tilted back, you can see there's some rubber banding that was placed. And what I want you to appreciate is that the buttons on one of them is on a crown. Actually, on both number 3 and 14 are on a crown. Have you tried to cement composite on a crown? I mean, it's been an absolute nightmare to make them attach. So I'm going to go into a little bit more into the actual attachments and talk a little bit more about what these, and if you take a look at the treatment, this is a 7-year progress. You can see that around the attachments, I don't have much staining. Around the attachments, I don't have really much other than the teeth staining themselves. I don't have the yellowness that you see sometimes with the composites that we've been putting on, or the actual adhesive that shows that yellow behind the attachments. And in this particular case, the attachments are still white. They're still squared. You can kind of see the actual extrusion attachments that have not been rounded on the incisal or on the edges of the actual attachment. That's important because as the patient takes the aligners on and off daily, you end up rounding out those attachments on the edges that you need to extrude, or the edges that you need for it to be beveled. And once it's rounded, unfortunately, what happens? It's no longer an attachment, it's just a blob. So again, take a look at no staining, very, very, very minimal. There's some staining on the patient's teeth, but not around the actual composite material attachments, as well as the composite material that was used to attach to a crown the buttons that the patient has been putting with a rubber band treatment. Now, as we start to move forward in the 12 months progress, I want you to show you that, this is the initial photos on the top left of the screen. You can see that prior to extraction, the tooth is kind of tipped in. You can see that again, beyond 20-degree tipping to the floor of the mouth are those bicuspids. Now you see in 12 months, we've got the rounded arch. The lower arch now fits just underneath the upper arch. The upper arch is starting to look a little bit rounder, if you can see on the top part of your slide on the right hand side. And most importantly, again, the attachments, no staining. He's been doing a little better, and I'm sure you've seen patients who come in for the recall. When they have a lot of spaces, they get a lot of plaque and buildup. He's been doing good in using the proxy brush and keeping his teeth clean. And as you can see, again, those anterior attachments that were placed from 6 through 11 have still held their sharpness to it. They still have no staining to it. And you start to look at this patient, and you want this 12 months progress to look good rather than a blob and a big stain. So again, no staining on the attachments, no real wear of them rounding out, and the patient has been comfortable where it's almost invisible because the color is also matched. If you can see with the teeth, we try to do a nice color match for this patient. So it's important to notice that, because I want to kind of go through in how to place the attachments, and then we'll talk about what the actual material that I'm using is, but most importantly, how to remove them. So let's go ahead and talk about placing the actual attachments. And obviously, I'm sure a lot of you know that before you actually place the attachment, you have to have that treatment plan or the video or what you're planning on, which teeth you're planning on putting attachments on or engagers on, as well as why you're moving them, right? Because sometimes you notice that there's small rounded attachments, or you've seen that there's 2 attachments or engagers on a particular tooth that are almost teardrops, very small. So once you bring that up, now you can try your attachment template. I always like to rinse these off because they tend to have a little bit of that disinfectant. It tastes horrible. And I always rinse off a little bit prior to trying, but I always want to try the attachment template to make sure it fits on. It is the template. I always have the cheek retractors ready. We have, we want to make sure we dry the template completely after we've rinsed it off, to ensure that when you're applying the etch on the enamel, and again, phosphoric acid etch is ideal. You want to leave that on 25 to 30 seconds. If you want to go longer, that's fine, but minimally 25 seconds. And you don't want to etch the entire tooth. You don't want to etch the entire, just the area, because you've already tried it on with a template and you've taken a visual memorization of where that attachment is going to be or the engager is going to be. So there's no need to have the entire tooth etched. And I, try to dry, extra dry, to where it's a frosty appearance on the actual tooth enamel surface. And if you want, you don't see the frosty surface, just re-etch, do it again. And for porcelain surfaces, like you saw on that crown, I use the hydrofluoric acid. And I use a dedicated porcelain repair kit, which I'll show you, that's being provided so that you can use that as a ceramic repair, but the composite you'll be using is the same composite that I'll be talking to you about. So as far as the dentin bonding goes, I just, any dentin bonding would work. I've been a fan of the Beauty Bond because it doesn't leave that residual staining. It's specifically made for these anterior composites. So you've seen sometimes where we kind of go crazy with the bonding agent, and that typically leaves that staining a few months after, or 6 months or 8 months later when the patient comes in. So I just leave the Beauty Bond for 10 seconds, and I just leave it on the etched surfaces that we already had. And you don't want to agitate the tooth, but you can air dry, just air dry gently without scattering the actual Beauty Bond or the actual bonding agent all into proximally everywhere. Just gently air dry. And at that point, I just kind of do a little bit more, and now I light cure for 10 seconds. So I just typically light cure with the halogen light. Obviously, if you have a LED, 5 seconds should be fine. So I know some of you using LED curing lights. That's fine as well. The 5 seconds should work fine. 10 seconds for the halogen lights. Now I use the Beauty Fill Flow Plus. Now there is two theories here. One is a actual composite. They're both composites that is called Beauty Fill, and the other one Beauty Fill Flow Plus. These composites come in injectable or packable. As you can see on the photo here, the packable on the right top of your screen, you have to kind of use just like you would any other composite that you're putting on a tooth. You put inside the actual attachment template, or the injectable. I'm a fan of the injectable composite. Remember, this is not flowable. You are not using flowable. Flowables delaminate, they pop off. So do not use flowable or a bonding sometimes for liners, none of those. A composite material is what you have to use in the attachment. So it's your choice whether you want to do a packable or injectable. Fully load the template area of the attachment template. Now you'll go ahead and, if you want to use a dental spatula to kind of put a little bit of pressure around the attachment area to make sure that it's adapted okay, and you firmly hold the actual template down. And again, I just, you can use college pliers or cotton pliers just to hold it against the tooth. You don't want to push it against the tooth too hard because it'll extrude and it'll get all over interproximally. Just enough where the template is now touching and engaging the tooth, and you go ahead and you make sure that when you light cure, you're curing for that 10 seconds, and now you go and remove any extra or excess. I do not go back and use a white stone or try to retake any of the extras around, because typically when you do it in this fashion, you won't have any residual material that's coming outside. So why I kind of wanted to go briefly over that, and I'll put this as a screenshot for everybody again so they can kind of see it in case you want to take a picture of it, or I will also have it, or you can go back and rewind and look. But why I talk about the material, the composite material, is important, because when you're using a restorative material, right? What is ideal for a restorative material? You want it to be fluoride releasing. You want it to have at least some sort of a recharge of fluoride. You don't want the fluoride to kind of dissipate within the first half an hour or hour of your utilization of the composite material. You definitely need to have a composite material that's neutralized, maybe acid neutralization of some sort, so it doesn't break down in acidity. You want it to be strong, not just flexural, but also compressive strength. You definitely don't want any shrinkage in that composite material, right? We've seen this many times. We put on a filling material and it shrinks, and here we are now stuck with having to deal with the margins that are sensitive inevitably. And obviously radio opaque. We want it to be radio opaque, and the color has to be stable. Whatever color we choose, it has to be the same color that you extrude out, and it holds its color during that timeline. So this is an ideal, in my opinion, of a composite restorative material. Well, the Guymer technology has all of these in it. What does that mean? So a Guymer product that's I've been utilizing, and Shofu's been in the forefront of having those filler materials, has the fluoride ion. It definitely has an antibacterial effect. It remineralizes. Most importantly, it's acid resistant because of the fluorapatite, and it is strong, and it does not shrink, and it inhibits any dental hypersensitivity. So a Guymer material that are fillers have the as you can see, the fluoride ion, all the sodium ions and silicate ions and borate, all of these that are needed for the longevity of the composite, and for it to not to discolor, not to have sensitivity, not to shrink, and ideally fighting, if you will, that fluoride to come back. Why I say that is because a lot of times composite material have fluoride in them, but after the first half an hour, studies show of a lot of composite materials, they actually release the fluoride and they don't recharge. What does that mean? What it means is that the fluoride is within the composite resin, the acidity hits it, and at that point, the fluoride is gone, dissipated, and it doesn't get recharged. The actual composite resin isn't and does not have the ability to release additional fluoride. So when you start to look at the different products in the market, most all of the composite materials are very strong, because remember, we talked about the composite attachment holding its shape during the time when the patient is taking the aligner in and out of their mouth. So when you start to look at the strength, most all of the composites in the market are very strong. Flexural strength is strong, compressive strength is strong, and they don't necessarily wear as quickly. They do have some wear to it. But when you start to look of the differentiation of shrinkage, you start to see that there's only a few products that are limited in that field, meaning that there is a lot of composites out there, as you can see on the slide, that have actual shrinkage. And that is a problem, right? So you want the lowest shrinking polymerization as possible throughout the course of this 5, 10, 20 year of this restoration. Most importantly, it's great for our composite attachments because we won't get that staining around that the adhesive sometimes shows when composite shrinks. So again, you start to look at the products like the Beautiful products, the Shofu products, and you see that the shrinkage and the light color stability is there. So you start, what does that mean? So look, have you ever put a composite, you look at a B1 or a B0 or an enamel shade, and you put it on, and it doesn't quite necessarily flow or have it exactly in the center portion the same color as the periphery. So you start to look at the before cure, and you start to see the center portion. And then when you light cure after, you notice that it's actually on the periphery is a different color. So color stability isn't just holding its color throughout the years, but rather right away when it comes out of the packet, is it going to be the same exact color in the middle of the composite as it is on the periphery of the composite? And again, multiple companies I've put here for you to kind of review and see which is the most ideal color stability. And now we get to the actual polishing. Why? Because we're going to start getting into actual removal soon. And the thickness of the actual hybrid composite is important, that it needs to be as small as possible, right? You want to have the nanofillers to be, if not nano crystals. Why is that important? Well, you can see in the pediatric world, or even in the adult world, we can see that there's sometimes those little stainings in between the teeth. You have to approach the staining that's an actual decay, as you can see on the x-ray on the upper right of their screen, that's actually through and through. We had to approach from a buccal rather than a lingual approach. Could you imagine for the rest of this on adult teeth, child's life, then adult teeth, he'll always have that staining that's ugly and nasty. So why the color stability is important, shrinkage is important, is because not only do I see the rhodeo opacity of the actual filling, but at least it'll hold its color and shape for the long life of that composite material with the Guymer in it. And again, we're starting to see that the composite resins, some of the injectable composites, are having some self-adhesion to them. What does that mean? So the actual composite has adhesive. It has adhesive within the composite resin where it avoids you having to put that extra composite resin bonding material. So if you can see where I had a tooth number 5 that was done by me about 10 years ago, and patient came in and it looked, you see the radial opacity started, lucency started happening. They started to get secondary decay on filling material. So I went right away and used the Guymer material with an injectable composite, putting that on the base layer, and then now flowing in and then packing it with the hard material. You can see how well the margins look and how beautiful the actual resin looks right away with no sensitivity or post-op issues. So getting into the adhesive section of this portion is important, because when you start to talk about the adhesion, if you remember from the back in dental school, some of you, or those of you have been now a dentist for over 20 years, but I remember, by the way, we had gold foil, so I'm glad none of you have to deal with that, or those of you who did doctors, you remember those memories. But white fillings were just coming out, and it was a multiple bottles we had to mix. There was multiple steps. Patients always had hypersensitivity, and then they called that generation 1, Gen 2, Gen 3. And by the 5th generation, where the etch and bond is getting a little better, we're starting to see the bond strength get a lot better. So the actual adhesive, the bonding material is now not in multiple bottles. You're starting to see that by generation 7, it's only one bottle, one bonding resin, one bonding agent, and you can now apply the composite after you light cure. And the bond strength is becoming much stronger than when it was 1 to 3 in the MPAs. And you can see 25 to 30 in the 7th generation of bonding material. And I believe that what's happened now with the Guymer technology is that now generation 8 has been released, and the bond strength is actually much stronger. And these are self-containing composite material, meaning you do not need to take a bottle and put bonding material after you etch. You instead can apply directly, like a class 5, a class 3 even, on light occlusal, or even use it for sealants. These composite resins now have adhesive within their material. And that's the Geimer technology that we're heading in. And that's been the 8th generation bonding composite, which is all in one. So, those of you who favor kind of the bioactive materials believe that bonding layers create barriers which inhibits the free exchange or healthful effects. Well, now you have the option of bonding directly with the composite in a case that you can see from class 5s to actual, as I said, sealants, pedo class 1s. And these are unique filler structures that combine light transmission and diffusion properties of dentin and enamel to blend in with the surrounding dentin. And that is the ideal situation for us in dentistry. And I'm excited about that. And I'm hoping that this continues and this 8th generation continues, that we now have to we can avoid the actual bonding layer. So again, the self-adhesive composites that have the Geimer technology that Shofu has launched are good for class 1 restorations. They're great for class 3, class 5, cervical caries, root caries. Some of the older patients, if you notice that they come in and they don't have the patience to sit and they have a lot of saliva and you're trying to quickly get that cervical caries out of the way, or children who are kind of moving and it's hard for your hygienist to put on the sealant without multiple steps of etch bond. Now you can go directly into the portion of sealant with just making sure that the tooth is dry and putting a light layer of about 0.5 millimeter or less. And the directions is very simple. So you just simply, if you prepare your cavity, you just put a 1/2 layer, 0.5 millimeter layer or less. You leave it undisturbed for 10 or 20 seconds. Make sure there's no fluids, no saliva, no salcular fluid. Then after the 10 or 20 seconds of you putting on that 0.5 millimeter layer, you can light cure. At that point, once you light cure for 5 seconds, you can now fill additional layers of maximum of 2 millimeter thickness. So if you have a 2 millimeter thickness in a cervical caries, occlusal fillings, again for pedos, as well as I mentioned for the sealants, these are ideal for the self-adhesive composite that is called FitSA, is what is been launched. So you can see in this particular area, multiple layers. I'm just putting on the gum line, and it's ideal for class 5s. Again, older patients, I don't have to traumatize the tissue with lots of etching. Now, I know some doctors like to etch anyway. That's fine. You can etch, but this was done without any bonding material. Rather, it's a self-bonding that I use for FitSA. Also for Marcos, he came in. This particular patient took a nice puck to the face back in 2019, and he was living out of state. He's in Ohio, and he was planning on going back to his dentist. And what was for me, I didn't want to go through etch, bond, and try to create a chair-side veneer for him because A, financials, and B, it was late at night and he had to get something done right away. So we simply just sandblasted a tiny bit and put on the material, the self-adhesive, no bonding, and just simply polished and light cured, as I said, 0.5 millimeter at a time. And it was enough for him to get by. And he was very appreciative, and his mom was very appreciative. And it took me milliseconds to do them all. So it was worth their time and my time in letting them know this is an alternative for now till you get to your dentist and have a permanent solution. So when you start to look at these composites with the Geimer, with a nano material that can be polished, it's important because once you're done with your attachments, or engagers, you now have to polish and clean or remove them. So, again, the idea of the Geimer is great in the composite. Now we have to start getting into potentially removal. Before I do, let me tell you this little story. So this young man that you see on the picture with a broken incisal third, this happens to be my own son. And this particular son of mine is very active. I've been through a lot with him. And his permanent adult tooth. I mean, could you imagine being a dentist and your son having a chip to the gingival third of the adult tooth? I said, well, let me bond the tooth back on. And unfortunately, I wasn't successful. When this happened in the morning, by the time they got to me, it was a little bit difficult to try to bond his existing enamel to the tooth structure. So as you can see, I took right away, you can see that, I mean, that the gum line, the distal third is completely, it looks like almost buried in the gum line. And so for me, sandblasting and putting on a Gymer type material that's anti-plaque, antibacterial, it's going to polish well. It polishes before and after every brushing. Why that's important? Because I don't want to see the staining on my son, 2, 3, 4, 5 years later. And luckily enough, he still has the same tooth, no staining, and the same bonding material that I've used. And again, I'm a big fan when I talk about this Gymer that it actually is and has anti-plaque properties. How many times have you done bondings on patients and you've seen just around the margin of where the tooth meets the actual composite, you have all kinds of plaque buildup? Well, here's proof that the image shows that within 24 hours, the plaque starts to build around the margin of the composite and tooth structure. So we want to make sure that these fillers, the Gymer fillers, are within our composite material. Now, we talked about removing attachments. So let's go into a little bit about how I go about removing them. So again, I bring up the patient's treatment plan. Sometimes there's attachments that are located on bicuspids or molars we had to put that I forget, or visually we can't see, or the light wasn't on. So you always want to bring up the patient's treatment plan to see all the attachments of where you've placed them. And I like to just define at the outline of the attachment with a sharp pencil. I just take a sharp pencil and just kind of define the outside margins of it. And that's important because I want to make sure that I see the areas that need to be removed, the bumps and lumps of the actual attachment or engagement material. So I go ahead and remove the outer 2/3 of the attachment with what's called Super Snap. I'm sure a lot of you know it goes from a black all the way to a pink color. And again, Shofu provides these different discs, and it has both sides, both the front and back of the discs and these are just plastic discs. They just bend. They're very simple to remove. They don't damage the enamel. I mean, unless if you simply put it on the enamel with the hard coarse, which is the black. So the coarse is black, the purple is medium, the green is fine, and then the pink is extra fine. And I go through that course, my first run of the 2/3 of the attachment outside of the attachment. And I kind of run that with a slow speed, running at maybe 10,000 or 12,000 reps. And that's good enough for just the top layer to be removed. You can still see the margins. I don't touch the pencil lines. So I go right just before the pencil lines. You can see in the photo here, I just get right to the pencil lines. And then you'll see a uniform material of tooth and the actual, the composite. And at that point, I remove that additional 1/3 with what's called the One Gloss. And that simply is the One Gloss polisher that you can kind of see that we kind of remove that, and that kind of starts to grind away like little pumice material, if you will. So as I'm kind of now polishing and removing with the One Gloss, you can kind of get to the enamel. You see the enamel show through, and it's not damaging the enamel. Why? Because the One Gloss actually starts to wear away once it touches the actual enamel. And I go back and do my final polish with the purple, green, and pink of the Super Snap. So everything's polished nice and smoothly. I don't have to worry about any damaging of the enamel or using a diamond burr or using a carbide burr afterwards. It's just simply clean and polished out. I know some doctors like to take a carbide and kind of go through and make sure it's smoothed out. No problem. But again, if you're using minimal adhesion and you're using the materials that are the low shrinkage, like this Gymer material, you can actually see the outline of the composite very easily. So we talked about that. And again, if you have any questions, type them in and at the end, I'll get to them. But what we haven't talked about, which is all the photos. Look, you must document your work. I do a lot of expert witness work, and attorneys call on me once in a while from patient complaint. I'm always on the dentist side. I'm part of the defense, typically on a dentist. And one thing that I've noticed unanimously that every dentist has been a victim of is not having proper documentation of your photo of attachments of before and after. So you definitely want to take a photo of what you have put on and what you've taken off. And again, this goes for your restorative as well. Doing before and after photos are great, but it's a task to the team. I know the team members have always complained that I don't want to take a photo. It's too heavy, the camera. It's too many numbers to remember. I don't know which one's the face and which one's intraoral, and it flips. I take the photo on the tooth and number 14 becomes number 3. It's too much work. And so I want to give you a quick little tip on just talking about photos and cameras. Look, I get that these big, huge SLR cameras are a challenge, and I'm anti huge cameras. So I've been very fortunate 5-6 years ago to kind of figure out my photo system, because just trying to remember all the settings and the apertures and the focus and all that has been a pain in the butt. And, having the team try to get a focal point of where's the focus and, the aperture settings on those SLRs. And now there's courses and courses being taught. And again, if you're planning on doing clear aligners or orthodontics, you must document your work. I mean, every visit, I'm taking photos on patients when they're coming in 6 to 8 weeks. So that becomes daunting for the staff to keep picking up the camera every time. So, deciding on the office camera was a big challenge. And I kind of want to go through and tell you what I use to kind of give you a tip that might help. And I get that some of you are very much into these big SLR heavy cameras, and some of you have them. I think they're great for weddings, but they're too heavy. They're very expensive, and they're not consistent with the magnification if the user doesn't know how to use them. And again, some of you might want to get those small cameras, like the little Sony cameras, or maybe your iPhone, or just something that's lower cost. Yeah, but the problem with that is that sometimes the resolution, there's an issue, and you get those dark corridors because of the flash. The flash doesn't necessarily come out nice. It just looks. I've seen these photos that it's a round blob of a pink and red tissues, and that's the gums and the tongue, and you're trying to make sense of it. So it's very difficult not to have a professional camera that's giving you that front flash, the outside flash, the side flash automatically. So what I've been using is the iSpecial digital dental camera. Again, Shofu provides this directly, where you can just simply, the camera has a built-in double flash. It's automatic. It's very lightweight. Given today's climate, you can wipe it with Cavicite all day. You can put it in the refrigerator, as a matter of fact. And not that we've done that, but it can handle the cold and extreme hots. It has an SD card that you can do videos and patient testimonials, should you wish, as well as photos. And it has that inside flash and the 12 megapixel that is actually, and now that the new version is even higher, that is got the optical zoom that's automatic. So when you start to see that the camera and video are going to take the photo, and it has that internal flash automatically, as well as external flash, you don't have to worry about any pre-shooting modules. It's already preset modes for you. They're all touchscreen, LDC, large touchscreen. Again, lightweight, water and chemical proof. And again, it's compatible with Wi-Fi card that you can just pop. And as soon as you take the photo, it pops up on the screen in your operatory. And those of you who know how to kind of connect the internet to the camera. So my team has been very excited. I have a few of these in the office. We don't have to worry about flash. We don't have to worry about moving the camera back and forth. We don't have to worry about whether we're going to be in focus. It'll always be in focus, and I'll always put the teeth in the right position of number 14 and number 3. It doesn't switch it on you. And those of you who want to see, you can go from standard mode to surgery mode. Those of you who do some gum surgery or implants, and it's for intraoral photography. It gives you that certain distance that you need for it to always be zoomed in. It does the mirror mode already for you, which it takes the image and it can be reversed, as well as the face mode. So it's just simply pressing a button of face mode, or the standard, or surgery, or the low glare. You're in an operatory where the light is flashing on the patient's face. You pick up the camera and you're just trying to figure out. You press that button, automatically these green lines show up, and as long as the green lines are in the grid shows up, you can take it. Otherwise, red lines show up until you kind of move it back and forth if there's too much lighting. So there's a whitening mode for teeth whitening, where you can take the before and afters, as well as the talking to shade. I mean, talking about the shade, isolated shade mode is important for me to communicate with my lab of what shade colors, of what a B2 or A2, what the patient's teeth actually look like. And it gives you the actual teeth shade that's to that patient's particular shade, rather than me having to kind of guesstimate, this is an A1 or A2. I share that photo and it gives the actual shade of the tooth. And again, the grid lines are always green, means you're in focus. It's that simple. You're simply moving it back and forth will help immensely. And those of you who kind of have experienced the iSpecial or have it, know what I'm talking about, your team will be amazed how easy and how quickly they can use it and wipe it down, like I said, without having to worry about cross-contamination. There is a video that I put together for you and how to take proper photos chairside within 2 minutes or less. So I thought I can show and play that video for you real quickly of how to retract the cheeks, how to get the patient participation of how to retract the cheeks up, down, and where to position the mirror, the intraoral mirrors. Those of you, I know some of you struggle, or some of your team struggles. I thought I can give you this little tip. Here we go.
All right, Nadia, so we're going to take some pictures, okay? I'm going to have you stand right against the wall. Okay, so for the first shot, you're just going to look straight into the camera. Do not smile. 1, 2, 3. Okay, now go ahead and smile. 1, 2, and 3. Go ahead, turn to the side. Look straight ahead. No smiling. 1, 2, 3. Perfect. Go ahead, have a seat. Okay, now we're going to take some pictures of your teeth. Go ahead, put your head back all the way. Open. And hold on to these from the side. Bite down all the way. Perfect. Stay just like that. 1, 2, 3. 1, 2, 3. And open a little bit. Perfect. 1, 2, 3. Bite down all the way. Bring this one to the middle, and I'll hold on to this. 1, 2, 3. Perfect. Hold on to this. Turn towards me. Bite down all the way. Perfect. Now we're going to take some of your top teeth. And for this, if you could breathe through your nose, that would be great. Open big. Open a little more. Perfect. And roll it down to the bottom. Open big. 1, 2, 3. Okay, perfect.
So as you can see, getting the patient participation and how to hold the cheek retractors, to put it down, to pull it up and having the patient where you're standing in front of the patient when you're taking the lower arch versus in behind the patient upper arch. And you can see that the camera was simply just zooming in and taking the photo with that grid. And as you saw, very simply, she just went from the module to the face, where she was taking the patient's face without those shadows that you typically see around the patient's face. So it's very helpful to kind of see how we do it in our practice. And those of you who are doing it the same way, fantastic. I also use these photos as a digital image. So if you understand, when you see a new patient in your practice, if they are insurance-based, typically they pay for a full mouth x-ray once every 24 months or 36 months these days. And so when the patient's coming in and they've taken the full mouth x-ray, in 6 months from now, what are you going to do? Take another set of x-rays? Well, the cavity, if it's still there, if the patient hasn't done anything about it, what's the point of taking another x-ray? And some insurances don't pay for that. So this is where a digital photo comes in handy. We actually take the photo, show the patient, kind of zoom it in. I know a lot of you have intraoral photos. We actually build this out as a digital image. And then 6 months after that, when the patient comes in, now a year has passed, we can do their follow-up x-rays or recall x-rays. And then the 6 months after that, we'll do digital photos. So a lot of times you can actually use this as not just an educational piece, but a revenue maker in your practice. So you don't have to just x-ray every 6 months, because not all insurances pay for that. And what are you going to see differently in that 6 months, unless if it's a particular tooth that's degrading? So I kind of wanted to give you that little tip of how I run my practice and some of the information that I was given to you. I'm hoping that you found fruitful. I hope that the understanding of the Zymer technology in our composite material, as well as putting on attachments, removing attachments, that's come in handy for you. I will also show you a little bit of video more about how you can use these adhesive composites that are the 8th generation now, I call them. And those are, I think, the Fit SA we talked about. That's a separate line item that I use for my pedo and some of the older patients, or any treatments that are 2 millimeters or less for restoration. So let me give you a quick little video on that as well.
Shofu's newest product, Fit SA, a self-adhesive flowable composite with Zymer technology inside, offers the dentist a better choice by eliminating the bonding agent and the technique sensitivity of placement. Fit SA improves the efficiency and production of dental practices by reducing the time required for each composite restoration. Representing a quantum leap in restorative technology, Fit SA is the better choice for patients with Zymer technology inside, absorbing and releasing healthful ions for the life of the restoration, which has been proven to strengthen tooth structure and provide antibacterial and acid neutralization effects. University of Florida Dental School confirmed there were no failures or secondary decay in any of the restorations, even after 8 years. Fit SA is the better choice for those who wish to maximize the effects of bioactive restoratives. By bonding directly to the tooth, Fit SA removes the bonding layer barrier, which allows the Zymer technology's healthful benefits to be transferred directly into the tooth. Fit SA is the better choice for use as a liner, Class 3, Class 5, and non-load bearing small Class 1 and/or PRR restorations. Simply prepare the tooth, dispense the Fit SA into the prep, and light cure. It's just that easy. Shofu Dental once again sets the standard as the better choice with Fit SA. This technological advancement is brought about by decades of proven expertise in bonding and restorative materials. Choose Fit SA as your better choice to serve patients, increase production, and go home on time.
So I hope that's giving you a little bit of a glimpse. I know we have a Q&A session, and those of you who have some questions, I'll go through them now real quickly and see what we've got. Sunny, great webinar, Payam Tufts 96. Thank you, Sunny. You're going to have to tell me your last name eventually. All right, Dr. Cho. Dr. Cho, so do we need engagers for spacing cases? Okay, so look, for spacing cases that are 4 millimeters or less, I don't use any engagers or attachments. If you have spacing cases with short clinical crown, and that short clinical crown is now where you actually need to grip the anteriors and lingualize them back, then you're going to need engagers or attachments, normally horizontal ones. So what defines a short clinical crown? If you remember on that slide that I showed you earlier, she had even though she had wear, she had pretty sized good crowns, and she was less than 4 millimeters of spacing. I hope that answers your question, Dr. Cho. Kyla, do you recommend polishing with pumice before etching? So in terms of polishing prior to etching, I think it's a little bit overkill, okay? Look, if the patient has had no cleanings ever, then yeah, you may have to do a cleaning and then pumice and then etch and then bond and then put your composite in the attachment template to put on. But if the patient's somewhat hygienic and the patient is coming in every 6 months, I don't pumice. I simply go with the etch. Now, again, you can take your Explorer and run it across the enamel. And if you see that big old plaque come up, then yes, you're going to have to pumice. The reality is I'm not a big fan of pumicing if I don't have to. If the patient's got plaque on their enamel, then yes. All right, so what's your opinion on poking a hole in engager template with Explorer and then putting composite in it and squeezing it down as it comes out the hole? That's a great question. So the question is, what's my opinion of placing a small little hole in the attachment template and that with an Explorer, and then the excess composite comes out? So twofold question. Number one, depending on the material or plastic or company you're using, poking a hole in some engager templates are very difficult. And it doesn't necessarily poke the way you're thinking. It's, if anything, it reshapes that engager or attachment and it pops it in. Should you be successful and actually poke the hole where you can get the composite to flow out, unless if you're using an injectable composite, necessarily that hole isn't going to be big enough for it to come out. So in theory, it makes sense. I'm going to poke a hole and I'm going to get the extra to come out. Well, if you're using packable, you're going to have a pretty significant hole. And that significant hole then is going to come as a blob when you light cure, just like you see when you cure, it could either become a void, a bubble, or it can have a little bump. Now you got to take your white stone and polish off that shape that you just created that wasn't the actual engager teardrop or attachment that has that particular shape based on the torque movement of the tooth or the surface area of the tooth. Now, if it's just a plain square attachment you're putting on just for retention, sure, you can give it a go. But I'm very much against poking holes, or I've even heard doctors spray with that Teflon spray. What is that, like a PAM spray that allows the composite not to attach itself to the plastic? Those kinds of things are only going to create more complications for you, and it's going to change the shape or potentially create a bubble that you don't want to have. I hope that's answered a few of your questions. And making template? One final question. Who is making the template attachments? The company that you are using for your clear aligner, the company that you're using for your clear aligner therapy is typically the company that makes the template attachment for you. It's either, let's say if you're using ClearCorrect or Invisalign or SureSmile or 3M soon to come out, the Smile Direct that's now going directly to the offices. So all of these companies will have their own attachment template that will give you. Unless if you're creating your own aligner therapy and you're printing your own teeth, that's a whole different lecture to itself. I hope you've enjoyed this brief, quick conversation. Any other questions, you're more than welcome to email me. And I thank Viva Learning for giving me this opportunity. I thank Shofu for supplying such great products. And I'll see you all next time.